It is my great pleasure to welcome Dr. Casey Parker as our speaker today to our Pearls lecture. Casey, rural generalist extraordinaire based in beautiful Broome, Western Australia. Casey, he was an early adopter of free open access medical education, and he's famous online along with offline for his extremely popular Broome Docs blog and podcast, amongst many other educational outputs that many of you will have seen. Actually, lately he spent a lot more of his time further south than Broome, down in Perth, where he completed his DDU, and he's now actually the lead of education for DDU teaching in that centre. This is Casey's third lecture for us. So his first was way back when we were just a spring chicken. Pearls was this just a lot smaller, way back in 2023. And so you're becoming a regular around here. Appreciate it. Casey, how are you, buddy?
I'm good. Thanks for having me back, Jono.
Um, really appreciate you taking the time. You know, I had a bit of a question to kick us off. I sort of see you like this superhuman super doc up there in Broome. You just have such a breadth of practice across anesthesia, emergency. You probably go sit in your GP clinic. I get the feeling you do maybe some obstetric care as well.
I used
But
to in
mm,
the past. Yeah.
But then you decided that's not broad enough. You wanted to just add ultrasound as another string to your bow. And I'm thinking, how on earth do you maintain such an amazing breadth of practice, It sounds
It's
impossible.
it is tricky. Having said that, though, when you work in the sort of place like Broome, necessity is the mother of invention. So, like when you're actually doing all this stuff every day. So, I'll give you an example for today, Jono. I am working. Someone's talking. I'm working in Broome, and I came in the morning. I was working in the HGU and saw some sick people in the HGU and fiddled with their ventilation settings. And then I went and did an epidural on the labour ward. And then there was a little kid that had an abscess that I had to do an ultrasound for to see if they needed a drain. And then I just intubated another patient in ED. And so when you're doing these things all the time every day, like you don't really lose the skills, and it takes a while to acquire that skill set. But I think if you're using stuff regularly, and I think the key to maintaining this is being a reflective practitioner. So if you're constantly second guessing yourself and not settling for being good enough, if you want to push for excellence, and you're constantly reading and trying to update your practice and make sure you're on the cutting edge, that's the challenge. So that's always been my mantra. Is I think that you should get the same care and Broome that you get in Melbourne or Sydney or Perth. So we push for that, and so it sort of behooves us as generalists to try and deliver as good a care as our colleagues do in the big city hospitals.
Well, that is pretty phenomenal. And anyway, you'll always be my superhero. But I say, without much further ado, take it away. First trimester pills.
Cool. I'm just going to share my screen if I can get the button. All right.
Round two.
So my career goal was always to have more letters after my name than are in my name. So I'm one of those nerds that just loves doing education. So I keep doing more courses over the time of my career. We're going to talk about early pregnancy ultrasound, and I'm going to try and give you a really practical sort of setup for how we do this. So there's three questions that I think that as a POCUS provider working in a sort of remote setting or somewhere that doesn't have dedicated obstetric services, for example, that you really need to be able to answer when you're doing first trimester scanning. And the first thing, obviously, what we're trying to do is diagnose a normal intrauterine pregnancy, which is what we sort of think about when we pick up the probe. We're going to find the fetus and hopefully say everything's great. And then once we've done that, we want to be able to do some sort of dating of that pregnancy. So I'm going to run you through sort of, a week by week, blow by blow, how we can date pregnancies. And then the most important thing that you need to know is diagnosing this thing called a pregnancy of unknown location, or a PUL, which sounds like it's not a real diagnosis, but it's actually a useful diagnosis to make as an ultrasound provider, because it's sort of a category that we know what to do with, and how to follow up, and how to counsel women who have this diagnosis. So these are the three things that I'm going to try and run through today. So the first thing I'm going to say is that usually with most ultrasounds that we do as point of care providers, we just walk into the room with a probe. We say, mate, you've got some belly pain. We put the probe on, we have a look. We don't really need to think too hard about pre-test counselling, but I think first trimester pregnancy is one where you really want to sit with the woman or the family and have a few minutes just to establish what their feelings and about the situation are. It may be that they didn't know that they were pregnant prior to arriving in your clinic or hospital. Maybe the first time they've been diagnosed, and obviously there's a lot of emotional stuff that goes on when that diagnosis is made, and that may be a good thing or a bad thing. So you need to establish how the woman's feeling about the pregnancy before doing the scan, and it's always useful to have a support person, partner or mother or someone with her at the time when you're doing the scan. I usually tell women that there's a few possibilities that we may see. One might be that we just see a normal, healthy intrauterine pregnancy, which is fine. We may see something that is bad news, like a miscarriage. And then I do say that a lot of the time we don't get a conclusive read and we have to do a subsequent scan. So I tell them that up front because women put a lot of weight on what the ultrasound shows, and it can be very disappointing and somewhat anxiety provoking if you say to them after the ultrasound, oh, I can't tell you what's going on. So I normally tell them that beforehand. And it's clear in my practice, if I can't tell, we do a transvaginal ultrasound, which is not something that is available to many sonographers and point of care providers. But you have to understand that is the gold standard. So a bedside transabdominal ultrasound is not the gold standard. And so you're doing something that can give you the answer, but often it lags a little bit. And so you may need to refer the woman on for either a scan in a week or so, or if you have that access to a transvaginal scan. All right. So here's my very simple algorithm. So you've got a woman in the first trimester of pregnancy. She may come in asymptomatic, and it's an incidental finding that she's pregnant, which is fine. But often we see women with either pain or bleeding in early pregnancy. And the first question I ask is, did we know that this was a previously documented intrauterine pregnancy? So they've had a scan previously. And if that's the case, it makes everything a lot easier because we know the pregnancy was in the right location at some point. And so we just carry on over the algorithm, and either it's still an ongoing normal pregnancy. If you have an inconclusive scan at that point, that's a bit concerning because that suggests that something's changed. And then sometimes we find women are having a miscarriage, and we'll go through the criteria that you can use to diagnose a miscarriage. And if it's obviously a non-viable pregnancy, then there's in your own system of care, you'll have your own management options for that, whether that's medical or surgical, or as is often the case in many parts of the world, just expectant management where you counsel the woman that this will take time and process and eventually she will complete that miscarriage. The diagnosis that we really care about is this thing called pregnancy of unknown location. And in the Australian context, that's usually someone that gets referred to a gynecologist for review and follow-up, or to some sort of early pregnancy clinic where they can get followed up. And so we'll talk a lot about that. And then obviously a confirmed intrauterine pregnancy, if everything looks good, we're just going to check the dates, make sure it's viable, and then we can organise a scan through whichever system of care you're using. So that's the basic algorithm that we follow in early pregnancy. So this thing called a pregnancy of unknown location, which basically means you've got a woman who's pregnant, you've done an ultrasound, but you haven't been able to localise a diagnosed intrauterine pregnancy. And what we know is that 2/3 of these women will have a normal early pregnancy, and that's just we're doing the scan too early before we can see the intrauterine contents and say for sure that this is a normal pregnancy. And then about 1/6 of them will have a miscarriage, and about 1/6 of them will end up having an ectopic. And those numbers change depending on how early it is and where you are in the world. But that's ballpark sort of figures, is that most of them will be normal, and then some of them will have either an ectopic, which is what we're really trying to exclude, or a miscarriage. We'll talk a little bit about quantitative HCG testing, which may not be available to many of you, unfortunately, but it's actually not a big problem if you don't have it immediately available to you in your clinic, because we don't find it that particularly useful for that first visit. We tend to take a quantitative HCG level mainly so that we can track it over time, but the ultrasound pretty much trumps the first beta HCG. And there's a huge normal range of what's going on. So we don't put a lot of weight on the individual number. We sort of look at what happens over the course of time. So obviously we're wanting it to go up and double every 48 hours. But that's not something that we normally get to follow up in our ED. So don't worry too much if you don't have that immediately available, because you can usually make decisions without it. So there's this old idea that this thing called the discriminatory zone, where if the HCG is above, say, 3,000, then you should be able to see an intrauterine pregnancy. But if I take you back to that previous slide, obviously there's a huge normal variable range there, particularly when you're around 3, 4, 5, 6 weeks mark. It can be very hard to see on ultrasound, and there's a huge range of normals. So I don't get too hung up on the absolute numbers. And as I said, the ultrasound findings, if you can make a positive diagnosis on ultrasound, then that trumps what the HCG told you. All right, this is, if you learn nothing else today about the actual technique of doing first trimester ultrasound, then this is the one slide I want you to take away, is that in order to say that this is an intrauterine pregnancy, you need to be able to show this continuity between the gestational sac, which is that little sac there with the yolk sac inside it, the endometrium going down to the cervix, and then out through the vaginal stripe. So it's like a reverse tick sign. And if you're seeing that, then you can say this is definitely an intrauterine pregnancy. And this is just one of those discipline things in point-of-care ultrasound, where you just have to spend time, move the probe around, twist it, rotate it, slide it, so you can get this picture so that you can say, yes, this sac is, I can see the sac, and yes, it's definitely inside the uterus. Because the only way you can really mess this up is by calling something an intrauterine pregnancy when it's actually just next to the uterus. And I'll show you some examples of that later on. A bit more about technical stuff. This is the standard picture that we see in the textbook. So you've got the probe just above the pubic symphysis. You're looking through the nice full bladder, and you can see the whole uterus. And you can see the cervical junction there at the far field, and maybe a little bit of vaginal stripe heading off towards the pelvis. And so that's what we want to get. But unfortunately, that's not how life is. And so often we get this picture where there's lots of bowel gas. And so particularly if the uterus is retroverted, so if it's folded back away from the probe, which is in about 10% of women, you can sometimes really struggle to see the full uterus. And so it's really hard to call these pregnancies. And no matter how much you fill their bladder, it doesn't get any better, unfortunately. And sometimes with these women, it's actually useful to try and empty the bladder to let the uterus hopefully antivert a little bit so that you can get it closer to the probe. And sometimes you get lucky with that. But these women often need a transvaginal scan so that the probe's in the right spot to see the pregnancy. Just be aware that that happens. Not having a full bladder, which is this picture, is a huge problem for us. And I spend many of my days in my practice in Perth waiting for women's bladder to fill, because I've learned this the hard way. If you try and do a scan, particularly in an anxious woman, before you've filled her bladder, and you get an inconclusive picture because there's too much bowel gas around, that actually makes the woman more anxious. And sometimes just waiting that 45 minutes, an hour, giving her some fluids to drink or some IV fluids, and just filling the bladder properly, and you get the right scan the first time. So sometimes I'll just plonk the probe on, and before I even try and look for anything, I'll just say, no, we need to fill the bladder more, because I don't want to spend time searching, because that's very anxiety provoking for women. So I tend to just move on and do something else and come back half an hour later and see if the bladder's fuller. And if you get the bladder really full, sometimes you get a great picture, but sometimes it pushes the uterus so far back that it's far away from the probe and you lose a bit of resolution. So sometimes you do need to get in and try and half empty the bladder, or let the woman go to the toilet, because sometimes it can be too full as well. So just be aware of that. So it's all about timing when it comes to bladders, unfortunately. So just have a look is my key. This is my colleague, Dr. James Rippey, who's my hero. He made this table, which you can print off. You can find on the internet. I'm sure Jono's already got it on his website somewhere. But this is just a really nice, quick, ready reference table that you can laminate, tie it to the end of your ultrasound machine, just so you've got these reference pictures and values available, because it's impossible unless you're sitting an exam to memorize all of these numbers. So I just have it printed out on the end of the machine so that when you get the pictures, you can refer to the numbers, and it's just much easier. And what I'll say is that for point of care ultrasound, when you're looking transabdominally with maybe an older machine, anything under 6 weeks can be very hard to spot, and even 6 to 7 weeks sometimes can be tricky to spot. But once you get past 7, 8, and up to 9 weeks, it gets a lot easier. So don't get too despondent if you're scanning women and they're in that very early phase, because I'd say half the time you won't see the pregnancy if you don't have everything lined up perfectly. So just be aware of that and include that in your counselling before you before you scan the woman. Say, look, your last menstrual period, we think you're about 6 weeks. There's a good chance we won't be able to see anything clearly today. Next slide. All right, so this is what we're looking for. So this is a normal intrauterine pregnancy. I've cheated on this talk by using a lot of transvaginal images because they're much clearer, but it gives you a good picture as to what we're looking for. So what we're looking for is a gestational sac, which is really a nice round oval sort of shaped sac, and it's usually got a decidual reaction around it, which is that hyperechoic endometrial fluffy lining, and then it's sitting in the center of the uterus, or often it's a little bit eccentric off to one side or the other within the uterine cavity. So that's what we're looking to see. So that's a 5-week pregnancy, and we can't really call that an intrauterine pregnancy because the rule is you're not allowed to say it's an intrauterine pregnancy until you've seen this. So you have to be able to see a gestational sac, and then within the gestational sac, you have to see a yolk sac. So it's a circle within a circle. If you're just seeing the gestational sac on its own, it's too early, or you could be looking at something called a pseudosac, which we'll talk a bit about in a minute. So you need to see a sac within a sac, if that makes sense, before you say, yes, for sure, this is definitely an IUP. So pseudosacs are essentially what a pseudosac is often in a miscarriage or in an ectopic pregnancy, for example, there'll be some bleeding, and some of that blood pools and collects within the endometrial cavity, and it can look for all the world like a small gestational sac, but it's not a gestational sac, and it's designed to trick us into thinking it's a gestational sac, and we call it a normal intrauterine pregnancy when it isn't. So that's why you need to see the yolk sac within it. So pseudosacs don't have a yolk sac in them. Pseudosacs are usually quite pointy and irregular, so they sort of look a bit teardrop shaped, often like a round thing with a long handle to it. And they're often right in the middle of the endometrium. So the trick is that gestational sacs are usually not perfectly central. We usually implant one side or the other. And there's often a bit of debris, but no yolk sac within it. So I'll show you a couple of examples of this. So the two at the top are pseudosacs. And you can see they're sort of flat. They're a bit pointy at the end, teardrop shaped. And they don't really have any, they've got something in them, but it's debris. It's not a nice round gestational or yolk sac. What we're looking for is a nice plump, round intrauterine gestational sac. And then we know that that's the right one. So the bottom one is obviously rounder and looks like a nice normal pregnancy. All right, let's just move through the weeks. And so this is at 5.5 weeks. We've got our lovely gestational sac there, and we've got a very clear yolk sac within it. So that can't be anything else. That's definitely a yolk sac. It's nice and bright and round. So we can call that an intrauterine pregnancy. So once we've seen this, unless there's something else weird going on, like in Australia, often we have women that are on fertility treatment and they can have twins that can be in all different locations. But a normally naturally conceived pregnancy, once you've seen an intrauterine pregnancy, you've effectively excluded an ectopic pregnancy. So you can relax and say, this is what it is. It doesn't tell you about viability or anything, but it tells you that you're not dealing with the ectopic, which is the thing that you don't want to miss. And then at 6 weeks, the yolk sac grows this little fetal pole on it, which is only a few millimeters long. So this one's 3 millimeters long, and we call this the diamond ring sign. So this is probably what you're most likely to see on your point of care machines. This is usually the earliest thing that you'll see is a gestational sac, a yolk sac, and usually the yolk sac just on one side has this little thick extra nubbin, and we call it like the diamond on the diamond ring, and you can measure that. And it's usually too small to see a heartbeat at this stage. So, but that's 6 weeks. We see the diamond ring, and then as 6.5 weeks gets a little bit longer, the diamond's bigger than the ring now at 6.5 weeks. It's about the size of a coffee bean. Sometimes we can see a heartbeat at this point, but it really depends on how good your pictures are. If you've got a very thin woman and a good machine, you'll see a heartbeat. The older machines or a larger woman, you probably won't see a heartbeat. And 7 weeks is sort of, at this time, it starts looking a bit more like a baby. So it sort of looks like a little jelly bean baby. hasn't got limbs yet, but you can definitely tell one end's the head end and one end is the bottom end, which you can't really before that point. And at this point, you should be able to see a heartbeat. So once you get up to 7 weeks, and once you're over 7 millimeters, the length of the fetus, you should be able to see a heartbeat. So by 7 weeks, we should be able to see a heartbeat, and then we can talk about viability. 8 weeks, obviously, starting to look more and more like a baby. You start seeing these little limb buds coming off, and this is getting up to 16 millimeters, so nearly half an inch, a bit over half an inch. And then once, obviously, you get past 9, 10 weeks, it gets much easier. You normally don't need to worry so much about filling the bladder at this point because it becomes much more obvious. And you start seeing the formation of the brain, the rhombencephalon, and definitely should be seeing a heartbeat at that point. So that's just a wishful stop tour through the first trimester. After 10 weeks, it gets much easier. Everything gets bigger and much easier to see. So the first sort of 6 to 10 weeks is where we mostly are dealing with women that come in with complications. So measuring the heartbeat, we tend to use M mode. So you need to have a very steady hand. You get a good picture of the fetus. And usually you can just see the heart just fluttering away. Sometimes it's just a couple of pixels on the screen bouncing up and down, depending on how good your picture is. And we tend to put on M mode and drop the cursor through the middle of that heartbeat, and then take a screen of M mode, freeze, and different softwares have different packages. Some want you to measure 1 cardiac cycle, some 2, but it gives you a heartbeat. And that's the best way to document that there is a viable live intrauterine pregnancy. Important that we don't use color Doppler or any active power Doppler modes on these babies, because we think it's safe, but it's just unnecessary. So we tend not to use any of the more sort of color modes or continuous wave Doppler, for example. M mode is the way to go. Now we'll talk a bit about pregnancy failure rules. So the simple one that we all think about is once the gestational sac gets above 25 millimeters, which is an inch in the old speak, you should definitely see a fetal pole within it. So if you've got a gestational sac that doesn't contain anything at 25 millimeters, then that is what we call an embryonic pregnancy. In the good old days, this was called a blighted ovum, but essentially it's a pregnancy that doesn't actually contain a fetus. And so that is by definition a failed pregnancy, and that gets managed essentially the same as a miscarriage, depending on your system of care. So if you don't see a fetus or you don't see a yolk sac, then at this stage we can say that it's a failed pregnancy. At 25 millimeter size gestational sac, I would expect to see about a 7 or 8 week pregnancy. So it's not a small thing that you're missing. It's quite a decent sized thing. It's probably around about 15, 16 millimeters long, the pregnancy at this point, the fetus. So you'll definitely see it if it's there. The other thing that we see really commonly in women, particularly women that present with bleeding, is a thing called a subchorionic hemorrhage. And essentially what that is a little bit of the maternal blood has bled around the side of the implanting gestational sac, and you get this little anechoic, or sometimes there's a bit of debris in it, little collection of blood around the side of the gestational sac. And if you see a little one like this, to be honest, I often don't even mention that to the woman because it's very common. It may be the cause of her bleeding. So sometimes I say, oh, look, this may be why you're bleeding. And it's really difficult to say what that means in terms of her prognosis for this pregnancy. But a small one like this is probably very common and happens in a lot of pregnancies and doesn't have any significance in terms of what's going to happen to the pregnancy in the coming weeks. Having said that, if you've got blood that's all the way around the gestational sac, that's usually a bit more of a worrying sign for miscarriage. And so there's nothing you can do about it, but it's one of those women that you may follow up more closely. A small one like this, I'd just treat as any normal pregnancy, to be honest. But it depends a bit on the situation and what else is going on with that woman. Oops. Can I get this video to play? Why won't it play? Play video. My videos aren't playing for some reason. All right, we'll move on to the next one. This is what we're trying not to miss. So this is a tubal pregnancy. And So the vast majority of ectopic pregnancies lodge in the actual tubes, and usually we see an empty uterus with no intrauterine pregnancy. You may see that decidual reaction. So in this picture here, you can see there's a bit of hyperechoic endometrium in the uterus, which is the thing on the left of the screen there. And then there's this ring sitting out in the adnexa on the left there, which is the pregnancy growing within the tube. This can be really tricky because if you see a mass like this, it's not always an ectopic, and a corpus luteal cyst can look very similar to this. And so it can sometimes be really tricky to say if this is truly an ectopic. And you sort of need to put it together with all the other information that you've got about the woman. And if you are seeing this and you're not sure, then this is one where you'd want to be moving towards getting a transvaginal scan. And there's other features that you're going to be looking for. So an empty uterus, a mass in the adnexa, and if there's any free fluid around, a significant volume of free fluid, then that's very worrying for an ectopic pregnancy. So this is a woman that's probably going to get admitted in our service and watch closely, and we'll hopefully get a formal scan, or sometimes we'll go straight to laparoscopy just based on this appearance alone. Obviously, there's other factors, but depends on the hemodynamics and what else is going on. But if there's heavy bleeding and the woman's unstable, they'll usually go straight to operation at this point. So this is an example of a corpus luteal cyst. So corpus luteal cyst can look, for all the world, exactly like a pregnancy or an ovary. So this is a thick-walled cyst, and it's got some hypervascularity to it, and it looks very similar to an ectopic. So this is a corpus luteal cyst, and this can be really hard to differentiate. I'll show you another example here. This is another corpus luteal cyst, so it's a thick-walled cyst with a bit of debris in the middle of it, and it's usually sitting in the ovary, and it can be really hard to say whether this is truly in the ovary or adjacent to the ovary. If you're doing a transvaginal ultrasound, we can actually push on it with the probe as we're doing the scan, and sometimes you can say that it's definitely in the ovary because it moves with the ovary. And what we're trying to prove is that it's not separate, and it's not a separate structure that moves separately to the ovary, i.e. an ectopic in the actual tube. If you see something like this and it's got a gestational sac with a fetus or a yolk sac within it, then you've diagnosed an ectopic. But that's pretty rare that we do that. I've only done that a handful of times in my career, but usually we just see a sort of mass sitting somewhere in the adnexa. There's an example of a ectopic sitting there next to the ovary, so they're two separate structures. But you can see the differentiating between an ectopic and a corpus luteal cyst, they look very similar, and that's really a tricky one. So if you've seen that mass, then you know that that's probably, and you're thinking ectopic, then you need to follow the woman as if it is an ectopic. This one at the top of the screen on the right there, you can actually see the gestational sac with the yolk sac within it, and it's next to the ovary. So that's actually a diagnosable ectopic pregnancy. We can say with 99% surety that is an ectopic pregnancy. Whereas if you're just seeing the mass without the yolk sac, it's a bit less clear, maybe 95%. The only other one that we think about frequently is sometimes we get what's called an interstitial pregnancy, and that's where the pregnancy implants into the very base of the fallopian tube right as it comes through the myometrial wall of the uterus. And this can be tricky because it can look exactly like an intrauterine pregnancy if you slice the uterus on just the right angle. And the way we differentiate this is normally a pregnancy has a nice thick healthy layer of myometrium, that sort of uterine muscle around it, whereas this one's only got a tiny little rim of uterine muscle around it. And if we saw that, we would be very concerned that that was a interstitial pregnancy. They used to be called corneal pregnancies, but we call them interstitial pregnancies nowadays. And sometimes you can see this thing called the line sign, where you can see a thin line joining the gestational sac back to the actual endometrial cavity. If you're seeing that, that's suggestive of an interstitial pregnancy. These are a bit problematic because they implant right next to the uterine artery, and they can bleed very badly quickly. So this is one we don't mess around with. We get off to theatre, or often they're treated with medical termination. See if I can get this one to play. Don't know if I can. Oh, it doesn't want to play. Oh, it's a pity. So we can come back to that. This was just a video showing that how easy it is to be just a centimeter off the midline of the uterus and see a pregnancy just outside the uterus. I can't work out why my videos aren't playing. I'm just pushing the wrong button. See if I can get it to play. No. All right. Another example of something that we see very rarely, but is worthwhile knowing about and just having in your mind as a possibility. This is a woman that presented with hyperemesis, so lots of vomiting in pregnancy, and we checked her beta HCG and it was 200,000, and she had some bleeding. And what you can see at the top of the screen here is the uterus, which has sort of got some anechoic debris and these sort of cystic spaces within it. It looks very unusual. And the other thing that you can see there with the big cyst is actually one of the ovaries. This is what's called a theca cyst, which is an ovary that's basically been hyperstimulated and is full of big cysts. So this is a woman that's got gestational trophoblastic disease or a molar pregnancy, and they often have super high hormone levels. They've usually got this sort of weird looking internal content to their uterus, and it's often cystic, and sometimes people talk about a snowstorm or a bunch of grapes, lots of little microcysts and some bigger cysts. And sometimes they have these hyperstimulated ovaries, which just look really big and full of big cysts, like a sort of almost look like a pepperoni pizza sometimes with cysts with lots of circles within them. And so that's just one to keep in the back of your mind. It can be really tricky to diagnose exactly what's going on, but often they have hyperemesis and often they have super high hormone levels. And this is one that really needs specialist follow-up because this is one that needs monitoring for weeks and weeks. And that's another example of a theca cyst. I'm not sure how much fertility treatment happens in your part of the world, but this is becoming more and more common in Australia, is that women that have fertility treatment to try and induce ovulation to become pregnant get put on hormones which hyperstimulate their ovaries. So often they'll present with these large cystic ovaries, which can be very painful with a lot of nausea as well. So that's just something you can take a mental snapshot of to think of. And don't forget to look in the right upper quadrant for free fluid. So I'm sure you're all super good at the FAST exam, but often with women that come in with bleeding, sometimes this is the best picture to take first, is do the right upper quadrant view. And if you've got lots of free fluid in the right upper quadrant in a pregnant woman who's come in with pain and bleeding, you sort of know where the diagnosis is going. Look, there's a few other things that can do that, like cyst ruptures and such, but this is a woman that you're definitely not sending home. You're going to watch very closely and may need to go to surgery urgently if they've got that much blood in their belly already. So we'll often, before we do the actual pregnancy scan, while we're waiting for the bladder to fill, just have a quick sneaky look in the right upper quadrant, Morrison's pouch, and the left upper quadrant, just to make sure there isn't obviously lots of free fluid, because that's a bit of a game changer if you see that one. I think that's my last slide, Jono. Have we got time for a Q&A?
We absolutely have time for a Q&A. Let me put my video back on, if I can figure that out. And Casey, fantastic. Thank you so much. And I'm sorry about your videos, but maybe we'll find
there's only two in there, but oh well.
Maybe we'll find a way to make them work. But I say we're going to stop the recording and invite everyone in for a discussion.